really appreciate being here. And I recognize that all of you are either doing research as it relates to children, and you may or may not be associated with the direct care of patients in the way that I'm talking about in terms of the recognition of delirium. Nonetheless, I hope that you will at least understand why this might be a particularly interesting condition, maybe even as it relates to the care of your parents as they age or your family members as they age. But also what I'm hoping I'll convince you about is the importance that those of us who care for adults should be talking regularly and frequently with those of us who care for children, because there's actually lots of reasons to be thinking about things and questioning our hypotheses, because I think if we do that, we'll actually improve care for both populations, for everyone. So we'll get to that. Okay. Oh, sorry. Okay, got it. It's not as if I don't see the screen all the time. Okay, now. Okay. There we go. We've got a connection. Great. So not really anything to disclose, except I'll be mentioning a few drugs, but not too much time will be spent, and I will not poison your mind. What I want to do is talk a little bit about what I mean by delirium and what the epidemiology is, the outcomes, a sentence or two about pathophysiology, only for those of you who are really interested. I know I'll gloss over that. A little bit about what we know about prevention and management in adults. And then I want to spend the last few minutes really talking about the implications of this research in adults and what kind of implications it's had for the care of children. Most of this is not going to be, we're going to be talking about critically ill people. So, it's kind of interesting. The psychiatrist comes to talk to you about critical illness, but it's all related, and I'll show you a little bit about why. So do you know what delirium is, first and foremost? How many of you have heard this term and feel like you know what we're talking about? Okay, great. We've got a couple. Yeah, great. Okay, wonderful. The rest of you probably think it's a beer, right? Okay, yeah. Well, it might be, but so delirium, interestingly, we have a very long literature about delirium in the medical record. So 2,500 years ago, Hippocrates was writing about delirium, the condition that we would refer to as delirium. And he described two different phases of the illness, or phases of the syndrome. I won't call it an illness because it's really an acute disorder, acute change in cognitive functioning, if you will. It's often associated with fever, with severe illness, and it results in problems with attention. So problems with being able to focus your attention. And that means if you can't focus your attention, you can't learn, right? And if you can't learn in the moment, you might forget where you are. You might have very grave difficulties even recognizing people or remembering who people are, or remembering anything for any period of time, right? So unstable, disrupted sleep and unstable moods are also part of this, that almost ubiquitous. So this is very, very similar to our DSM diagnosis. I didn't bother putting the DSM diagnosis because it's boring and dry. This description is really remarkably the same as what we refer to and what we find when we're doing consults on inpatient services in the hospital. So maybe if you think back, maybe to maybe a grandmother, or grandfather, or mother or father who's been hospitalized, maybe they got febrile, maybe they were all of a sudden really sick and they just didn't see themselves at all. They were talking about stuff, you didn't understand why they were talking about it, or maybe they were afraid, or maybe they were really, really sleepy. So maybe they weren't interacting at all. And that's the hypoactive form of delirium. Very easy to miss, because you think, oh, they're just sleeping. So I used to always tell the medical students and the residents that worked for me on the consult service, it's not okay that somebody's sleeping in the middle of the day. It doesn't matter how old they are. It doesn't matter how sick they are. They should be able to wake up and they should be able to interact with you. Don't give excuses just because somebody's older that they're sleeping during the day. It may be that they actually have a very abnormal mental state. It may be delirium. The hyperactive form, or phrenitus, as Hippocrates wrote about it, is actually something you really can't miss. It's when people are very motorically revved up. They may be getting out of bed. They may be, insisting that they have to leave the hospital, or they, sometimes they're really afraid and they don't know where they are. So oftentimes it's like a waking nightmare, and it's really hard because people have such difficulties with attention. You can't kind of remind them and get them back on track, or not for long, even if you can do it for a few minutes. So I don't know if that reminds you of anything, but we're going to come back to it in terms of children as well. But this is what I'm talking about when I'm talking about delirium. It's this state of mind that has a very acute onset, where the person is no longer acting like their normal baseline of maybe just a day or even a few hours before. It's often associated with some sort of bad medical thing going on. And here's where we're going to go with this. So where do we find it? You probably could guess already based on what I've said that you're going to find it in ICUs of pretty high proportion because people are pretty sick there. And you can see for the other areas in the hospital, there's quite a variety of prevalences. And this is because probably the sicker the patient, the greater the likelihood of delirium. Also, we have to be looking for it in order to know that it's there. Because if you're making excuses for people being too sleepy, or just not understanding that if they're acting very bizarrely in an agitated fashion, if you haven't taken into account their baseline, you may miss it as well. You may ascribe it to some other cause. This was work that was done by one of Sharon Inouye, who's really been one of the leaders in the delirium work amongst the elderly. And this was work that she did as part of a master's thesis, actually. She's a physician as well. She did an MPH, and this was her capstone project, which is kind of interesting. And she published it in JAMA, which is her want. She doesn't ever start low. She made the point that basically, whether somebody develops delirium or the likelihood of them developing it is really a combination of what the baseline risk is for any individual, as well as all the precipitating factors that we might throw at them. So what are the kinds of predisposing factors? Well, age is actually one of those predisposing factors. The older that you get, the more likely that you will transition to delirium in the inpatient, if you look at populations of people. Maybe not on an individual level, but of populations of people. Certainly as people age, you're more likely to find delirium. I also want to, because I'm talking to you, and because you are very interested in the other end of the spectrum, if we were to trace this line backwards down to early age, what we would find is a U-shaped curve, so that kids at very early life are actually also at a high likelihood of becoming delirious with precipitating factors. And so we actually see a U-shaped curve, and sort of the mid years are a little bit more protective, a little bit more resilient. But this is important when we come back to it later. Other vulnerability. So here's the difficulty when, as we become affected by illnesses that maybe result in dementia, eventually, so dementia or other sorts of neurocognitive disorders, we're actually much more likely to develop delirium. So you can imagine it's difficult to understand then when somebody's baseline is being altered by a dementing illness. You can understand how it might be difficult to pick up whether they're actually getting delirious or not. So that's another one of the really big factors, is anything that really affects brain health generally is going to make it more likely that somebody's going to fall ill with a delirium, or exhibit a delirium syndrome when they're ill. And basically any other medical comorbidities seem to have that effect as well. And then of course, various kinds of visual impairments, hearing impairments, so being deaf is also one of those risk factors for getting delirious, especially later in life, or other sorts of functional impairments, a history of alcohol use or drug use disorder might actually also predispose you. So the more predisposing risk factors, the more likely that you'll actually end up having a delirium. So as far as the work that we do in the hospital, we really want to target the highest risk to make sure that we don't miss delirium, the syndrome of delirium when they come in the hospital. But we're not going to talk too much about that today. Other sorts of precipitating risk factors, the things that we do that are bad for patients in the hospital. We give patients lots and lots of medicines in the hospital, outside of the hospital. So polypharmacy is another thing that probably does contribute to the risk. As I said already, any new intercurrent illnesses, alcohol and drug withdrawal syndromes, other sorts of fluid and electrolyte abnormalities, or people just not drinking enough in the hospital. I don't know if you've ever seen that. You come in the room and somebody's lips are dry and they can't reach their cup and they're not supposed to get out of bed and they're being yelled at for, being too restless and trying to get out of bed, and they're just completely dry and they need to be drinking and hydrated. There's, things like urinary retention and fecal impaction, which have been associated as precipitating risk factors. And as we'll talk about, immobility is probably one of the worst things that we do to people when they come into the hospital. Keeping somebody in bed is probably the least humane thing that we can do for people. And I'll show you a little bit more about the work in the ICU. So, and then of course there's environmental influences, physical restraints, things that act like restraints, like all these IVs or catheters that keep you in bed and keep you not being able to move, as well as uncontrolled pain and sleep deprivation. So, in ICUs, for example, well, it could be anywhere, any unit really. The level of noise at night is sometimes just unbelievable. It's because everybody's in night shift, they think it's day, and everybody's talking loudly, and they're cleaning the floors, and they're yelling to one another, the pizza is here, and somebody's trying to sleep, and there's really not much ability to sleep. Okay, so when I started in this area, basically, which wasn't that long ago. I mean, I've done a lot of other things before this. I know I'm really old, but I started really becoming interested in this area just as there was some interest amongst our colleagues to really do better with this and to pay attention to this. But most people said, ICU delirium, it's just something that happens. Just get the patient out and get them home, it'll be fine. They'll be fine as soon as you get them out. It's nothing. It's just a product of being in the hospital. Well, that it may be a product of it being in the hospital, but I think what we've learned is that delirium is actually associated with all sorts of short-term bad outcomes. So the longer, the more delirious someone, the longer that they have to stay on mechanical ventilation, that they stay intubated in the ICU. The longer their length of stay in the ICU, the longer length in the hospital. All of this, it's a no-brainer. It all adds up to being a much more expensive cost for those who become delirious compared to those who don't. And I think what's really important and what's been very compelling for me is the experiences that many people have during a delirium are terrifying. Not always, but often. And they're so terrifying, and they talk about them for years afterwards. They're really frightening experiences often. Or maybe it's that they didn't have anything in particular that was frightening, but the thought that they have this gap where they can't remember what happened, and they know everybody was really worried and scared, is really frightening in itself as well. So there's a great deal of patient suffering. And just for the families, it's really terrifying too. You're not only having to contend with a sick relative, but all of a sudden they're talking and behaving in such strange ways, and you're wondering, their brain has been affected, and it has, but you're worried about all sorts of consequences. Whether they have schizophrenia suddenly at 80 years of age is not an uncommon one, because a lot of these symptoms can be, hearing voices and believing strange things, but it's really in the context of this cognitive change. So lots of suffering, and I think that's not to be underestimated. I think that this is really difficult on families. So also delirium actually is, and pretty much Hippocrates talked about this, delirium was really sort of the death knell. It's really associated with death, and death in the year following your episode, much, much higher likelihood of dying. I'm not saying that it actually causes death. I'm saying it's associated with death. And I think it's an important point to make, and some of the implications might be interesting as well as we consider some of the things that we've been trying to do. Interesting, there's this dose response, and this was a colleague from Margaret Pisani from Yale who documented really the number of days delirious, and that you can see the survival curve. You can see that the greater likelihood of dying in the year following ICU stay was actually even in a dose response associated with delirium. And then I think cognitively, we actually note that cognitive outcomes seem to be worse with delirium in the year following discharge. And again, you can see on the bottom of this slide, you can see the days of delirium as well. The greater the days of delirium, the greater the decline in cognition using the R bands in this particular study. So functional decline, new nursing home placement is very common, and persistent cognitive decline are all things that we want to avoid or interrupt if we can, or decrease if we can. And this finally just is for those epidemiologists in the crowd, you say, yes, 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 but you're just looking at clinical populations. What about people who live in the community? And this was a study done by Daniel Davis, who's a geriatrician in the UK, looking at community samples of people who, so these are community samples of elders, those who had experienced a delirium based on review of medical records in these are some samples with some good documentation of medical records, and comparing those, even those with, you'll see that graph A is those with dementia pathologic burden. So that means at autopsy, they actually had evidence of the various kinds of things that we know are associated with dementia. Certainly there was an effect of delirium on the decline. You can see the difference between those lines, but you can also see the slope as steeper, and that is statistically significant, meaning is delirium actually somehow, hastening the decline? And that's really been the million-dollar question. The same was true for those people who didn't seem to have a dementing process at autopsy, although the slope wasn't quite as steep. And then this is just the pathology. There are lots of ideas about the pathology, and lots of things that are being really interrogated through mouse models and other kinds of strategies. And so, you know what, I'm just going to move on because I've got so much to say, and I realize that we are already at 26 after. So I'm just going to move on. But if some of you are just burning in desire to actually read about this, I can certainly send you the references because we've got some nice references. This one's a particularly nice one. So moving on to prevention and management in adults. So the first thing is that as physicians, and probably drug companies also like this too, we always want to have a cure. We want a pill. A pill is a good thing. If we could just give a drug and we can just get rid of it, wouldn't that be great? Well, it's so interesting because the first work that was done in this area was really trying to understand which drugs maybe actually help in delirium. And the very first thing we kind of figured out was, well, actually, the drugs that we use in the ICU seem to be associated with delirium. So in fact, instead of curing it, maybe some of the drugs that we're actually using are actually responsible, or at least maybe not responsible, but associated with the condition. And so looking in surgical and trauma ICUs, Pratik Pandharapandi documents here the increased likelihood of having more days delirious than not, with the higher use of midazolam, which is a type of benzodiazepine. So I know for those of you, I'm starting to veer into an area where you're sort of wondering where I'm going, but there's a class of medicines that we use for sedation. You know, Valium is sort of the grandmother drug of this class. Midazolam is a very common drug that we use in the ICUs and throughout the healthcare system to sedate people, to put them to sleep. So midazolam is used. Fentanyl, I think everybody's really familiar with fentanyl now. It's an opioid, but we use it. It's a great way to take away pain, and it's used very commonly in medical settings, but particularly where people can't take things orally, we can give these medicines intravenously. So interesting, opioids, and here's another one. Anytime you see PAM at the end of a name, it's a benzodiazepine, chances are. So lorazepam, a very common agent, again, that we use. Again, nice evidence that, you know, the higher the dose, the more likely we actually see people actually transitioning to delirium. And then you can see where that age graph came in. This is also clearly also is a factor that is quite important. So one of the things that we've really come to recognize is that we really shouldn't be doing harm, that we should probably not be using so many of these drugs, such as benzodiazepines like lorazepam or midazolam, and opioids if we don't need them, if there isn't an actual reason for it. And in fact, there's been a real culture change. So I guess some would say sort of the bad old days, but many people I'm sure still think these were the good old days. Patients are sedated. They come in, they're given like doses of midazolam, and they just stay asleep. And basically the evidence is that we're doing a good job because they're quiet and they are not moving and they're really still. You can see this gentleman's hand is really, really swollen here. That's just probably a product of not actually, you know, moving around at all. And that can happen, you know, throughout our bodies. This was really the culture before this whole discussion around delirium and around the increased risks of death. This was seen as the humane thing to do. What has really happened in the last 15 years is that this has really been challenged. And so now the ultimate goal is really to have people awake and alert when they come to the ICU so that they can communicate. This guy's writing, he's intubated, right? He has a tube that, in fact, this is day one of his stay in the ICU. And he was the first person recruited for this mobility intervention that we did in the ICU. And so he really represents, you know, that we want to be keeping people awake. So that means we do have to use sedative medicines because for example, in order to intubate him and make it comfortable enough to get that tube down, you better be darn sure we're going to give some sedation and we're going to be giving some opioids to make it comfortable. But here's the trick. It's really important to lighten it up so you can see, you can talk and he can become awake and he can sit up. And really important for my story is so that he can start walking in time, because walking is really important. Getting up and being mobilized is really important. So this now is kind of the new or newer culture that really ICUs are trying to move, and Society of Critical Care Medicine in the United States, really, and Canada, because there have been, in fact, Deb Cook has actually been one of the big proponents here at McMaster University of these kinds of interventions. So this is really seen as kind of much, much more important in order to really improve outcomes. And I haven't actually prepared all the sorts of data on how important this is, but suffice it to say, your survival rates, your ability to go back home and you know, continue on living with your life as it was before you were in the ICU is much, much greater with this approach than the bad old days when we just sedated everybody and said, we're doing them a favor. They don't want to remember this anyway. They need to just be asleep. They just need to be in a coma. So we still have this drive to find medicines to actually prevent delirium. And many people had been using antipsychotics, medications like Haldol or risperidone, see if we could prevent delirium by doing this. Unfortunately, there's no silver bullet for the prevention when it comes to pharmaceuticals. There really isn't all that much evidence that any of these actually are helpful in the long run. Maybe some antipsychotics are a little bit helpful in post-operative settings, but the jury is still out on that. And all of these medicines might be associated with side effects that aren't good in the long run as well. So no really easy news on this front. And we've looked at melatonin and melatonin agonists. Again, the findings are kind of mixed. And so I really think that the takeaway is that probably the best thing that we can do when it comes to pharmacologic agents is really to reduce the amount of sedation, the amount of psychoactive medications that people are exposed to, and really trying to change that culture in terms of alert and awake in the medical setting during the day, and asleep at night. I didn't mention that because that's actually part of it as well. And that there's less evidence for some of the other medications. For those of you who are tired of hearing about pharmacologic names, the only reason I put dexmedetomidine on here is that this is one agent that actually seems to be a little bit more cognitively sparing and is now kind of a recommendation for a lot of ICU settings if we need to use sedative medicines, especially when we're trying to wean somebody off of a ventilator. So if you're trying to advocate for your family member, I want you to know there are a couple of really good agents that we should use. So the non-pharmacologic strategies, as you might already imagine, because I keep talking about it, is that we want to do early physical and cognitive rehabilitation as soon as possible, as soon as we can get in there. We want to really improve sleep. We want to do kind of all of these things as bundled care, but early mobility is probably one of the most important things we can do for people. So getting people up and walking. In fact, when I had residents and they do consults, I say, did you get the patient out of bed? Did you walk them? Did you walk them down the hall? I mean, as long as the nurses are okay with it. But it's a really important intervention, and it doesn't matter who's doing it. It's just really important for people in the hospital who are desperately ill still to be mobilized and to be walking and to be engaging in all sorts of cognitive as well as physical activity. So really important to have people walking. This gentleman who was our first patient was actually somebody who had cystic fibrosis, so he was quite used to being in the ICU, and he had a lot of experience with being in the bed. And he said, bed rest is really unbearable after a time, and you really lose your dignity. And walking on the ventilator, having the ability to take your ventilator and be able to walk down the hallway, get around, is so very enjoyable. And he, of course, was encouraging us to get everybody up and moving as soon as possible. The sooner the better. So we really took a page out of his book in this work. So the summary of the ICU mobility outcomes are really that mobility does improve delirium outcomes, decreases delirium. It improves the physical function, the length of stay, all of these physical function, quality of life scores. But it's really important to do it early and not wait weeks before you get started, because you lose a lot of ground early on. And of course, it goes hand in hand, doesn't it? If you reduce the sedation, then you can actually mobilize somebody. If somebody's in a coma because we've been giving them benzodiazepines, you can't do very much for them. You can't really interact with them. So probably the sedation practices are so detrimental because we're not able to do these other exercise interventions that are really important. So yeah, mobility matters, not who delivers it. We can't prevent all delirium, let's be clear, but we can probably prevent about a third of it if we do good practice with our bundled practices. So that's why I think it's still really important. It's still, even though it's not a complete answer, it's important to be looking for it and preventing it as best we can. So I just wanted to show you some pictures. So this is from some Japanese colleagues who were implementing some of our early mobility work. And, somebody reading a newspaper, somebody doing Sudoku, all of these people are ventilated in an ICU. This is actually Michelle Coe. I don't know if any of you know Michelle Coe. She's a professor here at McMaster University when she's in the School of Rehab. She came and did her postdoc with us at Hopkins. This was her walking one of her patients, one of her mobility interventions outside in the sunshine. And this is a bike that you can put in the bed. And I think that, these are really important. We have actually lots of bikes. In fact, I think Michelle is actually just finishing up a randomized controlled trial in the ICU with this kind of technology. And then we have, I thought that was cute. And then these are colleagues from Germany. They've got a pool that they take patients in. I don't know, it's kind of over the top, but it kind of looks good. Okay. So what about kids? Are kids small adults? No, they're not. That's always the answer. But do they get delirious? And this picture, I think I still remember getting very delirious as a kid when I was very, very sick. And I still remember the exact, dream or hallucinations or whatever. It was a giant mouse. I still remember. So I see this picture and I go, yeah, I remember. It's a terrible experience. So yes, kids do get delirious. I just wanted to show you, this was just to remind me. So Wes Ely is actually the ICU physician who started figuring out how to measure delirium in the ICU really quickly and training nurses to look for it in the ICU. And so he's been focused on adults, and he's a great mentor to lots of people and was really great proponent for this work. And I remember he came once to Hopkins, I think it was about 2012 or maybe it was 2013. And we were talking and he said, yeah, I was at this meeting in Europe and I started talking to pediatric colleagues and I started asking them about this, like, what are you guys doing? And they say, oh, no. We keep these kids snowed. Like, we keep them completely snowed. We couldn't possibly do anything like what you're talking about. And he said, really? And he said, like, how much are you using in these kids? Said, oh, well, we actually, a lot of kids develop such tolerance when they're on opioids and when they're on benzodiazepines that a lot of children are going home on methadone, so a long-acting opioid, for months because they develop such high tolerance, and on Valium and other agents that they can be withdrawn from because the implication is such that they're so addicted because they become addicted so easily because their systems are so pliable. And Wes said, do you think that's good for development? I mean, do you think it just seems to me that's a bit of a problem. Anyway, my colleague, Dale Needham, who is here at Mac before he came to us at Hopkins, was really the ICU physician who was most interested in how to get people mobilized in the ICU. And each of these guys ended up mentoring these two terrific women, Sapna Kajarkar and Heidi Smith. Sapna's from Hopkins and Heidi's from Vanderbilt. These are the two pediatric anesthesiologists who have really carried the field forward. So in 2014, I remember them sitting down with me and saying, we can't seem to get anybody to listen to us about this. And since then, they have I'll show you a little bit about what they've done. They've just really done an amazing job of asking questions and trying to figure out how to do a little bit better with the answers. So this is kind of like what the ICU was like, and still is in many, many places, but the idea was that you're doing good if you just keep your tiny little folk sedated and basically in a coma for the time that they need to be in the ICU. But you can see this isn't really great for development, right? And not for days and days. Right, okay. So So first of all, it was just very clear that pretty much everybody was doing the same thing, that everybody was using high-dose benzodiazepines and opioids. And here's that vicious circle that I was alluding to, that, you know, you have sedation needs. Your kids have very, very great ability to metabolize and really get used to drugs much better than adults. And so that means that their demand goes up and up, so that in order to get them to go to sleep, you need more and more. Unfortunately, their sleep quality, because this isn't real sleep, this is just sedation, which is different than normal sleep. This just means that the child actually gets more delirious. They're being given more and more medications. They're not sleeping. They're given more sedation. And you can see this is just this vicious circle where you're trying to chase your tail. And that's how you get these high use cases where you may have to take months to get people weaned or keep these little people off of these medications. So not great for development. And the first job that those two women had to do was figure out how to measure delirium in the ICU. So amongst our verbal folks who are a little bit older, and this is just a picture of this guy when he was not delirious and the picture of him when he is delirious. And you can sort of see that sort of vacant, not focused, not, you know, attention not there. So with someone his age, we can probably use, with just sort of some modification, we can use the tool that Wes Seeley had developed for adults, which is doing some attention testing and asking some questions about thinking and making some observations. So that's not so hard. But what about this little guy? How do you test his attention? And so actually what you're seeing here is, this is Heidi Smith's tool. She actually has a number of pictures, like bright pictures, and solved, sort of neurodevelopmentally informed, as well as a mirror to, you know, and the attention task is actually showing the baby, you know, the mirror as it goes across their visual field. And you can sort of see whether or not they're actually focusing and attending to the stimuli. Anyway, it seems to have worked. She has seemed to have really made a great tool that you could actually discriminate in these small folk. And so they demonstrated the prevalence of delirium, and the incidence of delirium was actually pretty high. So a good third of kids, or up to a third of kids, or a half of kids undergoing cardiac surgery were actually found to be delirious with these tools. The same things that I showed you in adults: bad short-term outcomes, and fourfold increase in mortality in the year following the delirium episode. So same signals. It's not a good thing. It's just like Hippocrates. This is not a good thing. It's a signal the brain's not doing well. It's not a good thing. So basically, Heidi Smith actually did this work. She, again, very much just sort of replicated the same things that had been done in adults and looked at kids. And once again, you know, the sicker the patient, the more likely that it will be that they have delirium. That's that pediatric risk of mortality score. But the thing that we can do something about are really the exposures. And once again, remember the benzodiazepines, the drugs that end in PAM? They once again were sort of, you know, raising at least the risk of delirium was certainly associated with the use of benzodiazepines. And this was replicated in a number of studies, and as well as a recent +1 systematic review. Again, you know, benzodiazepine use is probably the one thing that we can change in the pediatric ICU, which means less sedation, right? So, and also, you know, there were these studies in a rat model, a mouse model, looking at neurodevelopmental effects by benzodiazepine drugs themselves that had, you know, that is frightening. And, you know, again, motivates us to want to decrease kids' exposure. So we really want to use drugs like midazolam, you know, only when it's indicated, and not for sedation if we can get away with it. And this is in kids. So this is where we've moved to, at least not sedation in the ICU where they're staying for days and days. So, you know, the causes of ICU delirium in kids are probably, you know, multifactorial, but benzodiazepines, just in summary, are probably the one thing that we can do a little different in our practice. And you know what? The movement amongst the pediatric ICU group has been tremendous. They've really embraced a lot of the work that has been done and are really trying to move in that direction. The problem, you'll see the two red boxes here, we're still not doing a whole lot of delirium monitoring in ICUs across North America, and we're not doing that much early mobility because it's kind of that culture change again. It's kind of scary to do some of this. People are worried about it. And so I think that probably one of the things, though, that there's this idea that you're not, that you can't mobilize a child with a trach in because it's too dangerous, and that you will cause maybe PTSD in the child, or you'll have some sort of horrible consequence. It's really interesting, but recently there was this paper published here that I've put on the board here, just looking at midazolam and its association. In fact, the more benzodiazepines that you use, at least in this study, was associated with greater levels of PTSD. In other words, that delirium association might in fact be a greater cause of delirium rather than decreasing the level of delirium and getting kids up and mobilized. But it's a big lift for lots of units. And so people are really reticent because they aren't sure that they can sort of maintain the safety of their kids when they start mobilizing them. Thanks so much. Oh, yeah. So this is what it looks like when you've made that shift and you've actually, just like the adult ICU pictures I was showing you, you can see these guys their eyes are open. And although they're intubated, they seem like they are on board with what's going on around them. It doesn't mean that everybody's smiling and happy when they're awake. You can imagine an unsedated baby is a lot harder to care for than a sedated one as far as the nurses, but it's a whole lot better for them. Okay, I know my internet is unstable. Okay, so, we have, this little girl actually had a pet cow as well at home. She was from a farm in Maryland, and so they brought the pet cow to the ICU for this little calf so that she could see her pet calf. Anyway, Sapna Kajarkar is an amazing person. Only Sapna would figure out how to get a cow up to the ICU, which is on the 10th floor. So anyway, but here are some of the pictures, up, mobilized, walking, on a bike. And so I think the answer is it's really important for us to be talking about the care of adults. And we should also be thinking about the care of children as we have those conversations. No, they're not little adults. I think that we all agree. But there may be things that we can actually share and that we can really improve the culture of safety and care for patients in the hospital setting, in this case with delirium, through our conversations and coming together. And so I'll stop there. Thanks.